Hello students. Today we are going to discuss about the anatomy of optic nerve. Now before starting this lecture, please watch my previous two videos based on the embryology of retina as well as the structure of optic disc. So in today's video what we are going to discuss is about how the optic nerve comes out from the eyeball and its termination till the optic chiasma and the relations. So let's see one by one. So first, when you will see the optic nerve, you should keep this thing in mind that the optic nerve is the second cranial nerve, which you all know, and it is formed by the axons of multipolar second order ganglionic cell of retina. Now, see, this line is very important because when we are talking about the formation of optic nerve is a second order neuron because the rods and cones are the photoreceptor and their sensations are received by the bipolar neurons. And these bipolar neurons further make synapse with the ganglionic cells and the axons of ganglionic cell come out from the retina. Now these fibers later on going to form your optic nerve. But these ganglionic cells are not bipolar, they are multipolar neurons. So this is the question of your exam. The second thing is that when we will talk about the function of the optic nerve is a spatial somatic afferent and it is for the vision as well as it conveys the afferent part of the pupillary light reflex and accommodation reflex. So what is about this slide? There are two important things. First, it is formed by the second order neurons of the ganglionic cell, and second, it is a spatial somatic afferent nerve. Now we'll move to the peculiarities of this nerve. Now when you will see the optic nerve is made up of around 1 to 1.2 million of myelinated fibers. Now when we are talking about the word myelination, that means the myelination is not in the initial part of the nerve. That means when you will have this arrangement of the retina, you know that the innermost lining is known as internal limiting membrane. Now below the internal limiting membrane, you have the axons. Now these are the axons of these ganglionic cell. Now once you are present inside the eyeball, that means just below the internal limiting membrane, at this point these axons are unmyelinated. But when we are talking about the optic nerve, that means when the optic nerve fibers, that means these fibers come out from your globe, from your eyeball, then the oligodendrocytes make them myelination. So the ganglionic cells give rise to the unmyelinated axons, and these unmyelinated axons convert into the myelinated nerve fibers of optic nerve once they will exit your eyeball, because oligodendrocytes, which are responsible for the myelination, are absent inside the layers of eyeball. Clear? Now this myelination starts after the optic disc. Now which cells are responsible for the myelination? Answer is oligodendrocytes. Now it is separated from the vitreous body by the internal limiting membrane. So I told you the internal limiting membrane separates the axons of your ganglionic cell from the vitreous body. Now the axons acquire myelin sheath. At what point they acquire myelin sheath? As they leave the optic disc. Clear? So in the class of optic head, I already explained this very well, that optic head means the blind spot into the eyeball where we don't have the neurons, and in this optic head you are having the three areas: prelaminar, laminar and postlamellar areas. And in which areas, as soon as the optic nerve pierces the lamina cribrosa of the sclera, after that the myelination starts because oligodendrocytes are not present in the inner layers. Clear? So now we'll move to the another important peculiarities. Now this optic nerve is not considered as a peripheral nerve. Now why not as a peripheral nerve? Because peripheral nerves are having the neurolemma. They are surrounded by the sheath of Schwann cells. Now these are considered as a extension of the white matter, because when you will see the embryology, you will realize that the optic nerve is a outpouching of the diencephalon. It is a extension of the diencephalon, which is the white matter of the brain, and later on it is going to form your nerve. Now it is covered by all the three meninges, because when it is extending from the diencephalon, you know that brain is covered by the meninges. So meningeal covering are also present all around this optic nerve. And because of that, what will happen? You will see that the subdural space and subarachnoid space are also present around the optic nerve. So subdural and subarachnoid spaces are also present around the optic nerve. The dura mater, if you will see how it ends, so this dura mater, which is the outer layer, will go and it is going to merge with the outer layer of eyeball, that is known as sclera. Clear? Now, this subarachnoid space, now when you will see, suppose this is our eye and here is the optic nerve. Now, around that you will have the subarachnoid space. Now, the subarachnoid space is extend anteriorly, and this subarachnoid space is become a dead end. Now, here the subarachnoid space becomes the dead end, and these are known as cul-de-sac. So, what is cul-de-sac? That subarachnoid space dead ends near the sclera. Clear? So, elevation of the intracranial pressure is a important thing, because whenever the CSF pressure is high, whenever the raised ICT is there, this raised ICT is going to compress this optic nerve. So elevation of intracranial pressure transmitted to the subarachnoid sleeve around the nerve, and in the case of raised intracranial pressure, this pressure transmit to the optic nerve and it will lead to the papilloedema. Now, when you will see this section, of the eyeball, what you are able to understand, that this is your optic head, which is a blind spot from which the optic nerve is start. Now here you can see that this is your subarachnoid space, which is present around the optic nerve. Now when the pressure is high, now this higher pressure going to compress this nerve, and you can see that this is your central vein of retina. Now these are the tributaries of the vein. Now when the pressure is there, but obviously the venous drainage is hampered and these tributaries will dilate. And for the very first sign is you will have the swelling in this optic disc area, which is known as papilloedema. Clear? So whenever the raised ICT is there, there is a presence of swelling or papilloedema, and it is considered as one of the earliest sign in case of raised ICT. Now, when you will see the meninges, the innermost meninges is known as pia mater. Now, this pia sheath carrying the blood vessels which are projecting into the substance of the nerve, and they are also one of the very important source of blood supply to the optic nerve. Now, I already told you that myelination of the nerve is derived from the oligodendrocytes, and from which point? Outside the eyeball, as it pierces the lamina cribrosa of sclera. Now, the optic nerve cannot regenerate if damaged. Now, this is a very commonly asked question, that why optic nerve cannot regenerate if damaged. Now, there are these 2-3 lines which you have to always keep in mind, that myelination of the optic nerve is done by the oligodendrocyte, not by the Schwann cells. So if you will see a normal nerve, now this is a nerve, peripheral nerve, and around that what you are able to see, that these are the circles and these is a lamellar arrangement of myelin sheath formed by the Schwann cell. But the outermost layer, if you will see the outermost layer, where the cytoplasm of the Schwann cell is present as a thin layer along with the nuclei, and this is known as neurilemmal sheath or neurilemma. Now this neurilemma is a prerequisite for the regeneration of a nerve. But when you will see a optic nerve, you don't have the neurilemma, because the myelination is done by the oligodendrocyte, and single cell will have the multiple processes for the myelination. So it is not able to make such kind of covering or the layer around one axon in form of neurilemma. Plus there is an absence of endoneurium. So because of these two reasons, there is a lack of regeneration, or we can say that once the optic nerve will damage, it will not regenerate. Clear? Now, if you will see this diagram, now what this diagram is showing, now here if you will see this posterior part, here what you are able to understand, if you will zoom this area, you can see that the paya matter, now this is the outermost, this is the outer part of the optic nerve where you will have innermost paya matter. Now this is also sending the blood vessels inside. So this is also one of the source of the blood supply of your optic nerve. Clear? Now we'll move to the next peculiarity. So how the optic nerve will form? So if somebody will ask you how the optic nerve form, draw the flow chart. So you will start from the ganglionic cell. Ganglionic cells are present in the retina, but the important thing which you have to understand that these cells are unmyelinated. So you have to keep this thing in mind. There is a unmyelinated axons of the ganglionic cell. They will form and converge on the optic disc, which is a blind spot. From the optic disc, the axon become myelinated. As soon as they will come out from the lamina cribrosa, they will form the optic nerve. Optic nerve then exit the eyeball, and once it will come out on the posterior side of the eyeball, it will run into the bony orbit, then it will pass through the optic canal, and finally it will enter into the middle cranial fossa where it joins the opposite side of optic nerve to form the optic chiasma. So when you will see the optic nerve starts from the eyeball and it will end at the optic chiasma. Clear? So that is the optic nerve. So see, the students are having confusion between the visual pathway and optic nerve. So when you will have the question on optic nerve, there is no need to draw the whole visual pathway, because visual pathway will go towards the cortical connections, and we are not discussing the visual pathway. We are stick to the optic nerve which ends at the optic chiasma. Clear? Now, how to read the optic nerve? So when you will see the passage of the optic nerve, we divide it into the four component. Now what is that? One is the intraocular. Now intraocular part is known as optic nerve head. After that you will have the intraorbital, that means the part in the bony orbit. Then it will pass through the optic canal, which is present into the your lesser wing of sphenoid, is known as intracanalicular, and lastly it enter into the middle cranial fossa, is known as intracranial part. Now if you will see the length of all the different parts, the intraocular part is hardly 1 mm, and intraorbital part is the longest part, is around 2.5 to 30 mm. The canalicular part is only around 5 to 10 mm, and the intracranial part is also around 10 mm. So what is the total length of optic nerve? So it is somewhere around 5 centimeters. So this is your MCQ for exam. What is the length of optic nerve? Answer is 4 to 5 centimeters. So let's see one by one all the parts. So first is the course of the intraocular part. Now the detail of intraocular we have already discussed in the lecture of the optic head, but still if you will see, it begins at the optic disc head. Optic disc head, I again saying that it is a blind spot because it devoid of the neurons of the retina. Now from this point, the intraocular fibers which are unmyelinated pierces the all three layers. So first it will come out from the retina, then they will pass through the choroid, and ultimately they will puncture the lamina cribrosa which is present into the sclera. Now as soon as they will come out from the sclera, then the myelination will start. Now when you will see the optic disc, now this is the eyeball. Now if you will see the optic disc is not present into the center point. It is 3 to 4 centimeter on the medial side or the nasal side from the posterior center. So it is located 3 to 4 mm nasal to the posterior pole of the eyeball. Now this point is the optic disc from where you will have the exit of optic nerve. The myelination begins from this point. So what is the important thing? That optic disc has no photoreceptor. That's why the optic disc is known as blind spot in the retina. Now this section is explaining this whole knowledge, that this is your center and this is the posterior pole, but this posterior pole is not having the exit. The exit is around 3 to 4 mm on the medial side where you will have this optic head. Clear? Now we'll move to the next part, is the course in the orbit and the canal. Now, dear students, when you will see this diagram, what you are able to understand that this is your eyeball and this is your bony orbit. Now, this bony orbit is having the more straight medial wall and the oblique lateral wall. So, because the lateral wall is directed medially, so the optic nerve will also directed backward and medially towards the apex of orbit. So when you will see the course, the optic nerve runs backward and medially in the posterior part of the orbit. Clear? Now it passes through the optic canal. Now here at the apex of orbit you will have the optic canal. So this nerve will passes through the optic canal and join with the optic chiasma when it enters into the middle cranial fossa. Now the important thing is that when it is present into the orbit, it is having a spiral course. Now this course is spiral. Now why this nerve is having a spiral course? So that it allows free movement of the eyeball without stretching of the nerve. Clear? So when you will see the whole length, if you will see the length, you will find the variation is around 6 mm if it is straight, and if it is spiral, that's why spiral nerve is 6 mm longer as compared to the straight nerve. So we are actually accommodate the larger length of this nerve in the this space to allow the free movement and avoid the stretching of the nerve. Clear? Now, what are the relations? So first we will see the relation of the orbital part. Now when you will see the relation of the orbital part, we start with the posterior relation. Now when you will see the posterior relation, you know that posteriorly there are all the 4 recti which are arises from the tendinous ring of Zinn, which is known as annulus, and it is present near the apex. So this is the apex. Now here near the apex of the orbit, you will have the annular ring. So all around it is surrounded by the ring. The origin of superior and medial rectus. Now see, this is the important line, because when we are talking about the applied anatomy, when you will have the optic neuritis, these two muscle actions are also having the affected, these two muscle actions are also affected. Why? Because the origin of superior and medial rectus are adherent to the dural sheath of optic nerve. So this is the important line which you have to keep in mind, that the superior and medial rectus not only arises from this ring of Zinn, but they also arises from the outer dural sheath of optic nerve. Clear? So therefore, if there is a retrobulbar neuritis, that means whenever there is inflammation in the optic nerve, the elevation and adduction of the eyeball causes pain. Clear? So this question may be asked, why the medial rotation, that means adduction, and upward rotation, that means elevation of the eye, is painful because of the attachment of superior and medial rectus with the dural sheath. So whenever there is an inflammation or the neuritis is there, these movements are particularly painful. Now what are the anterior relation? Now if you will see anteriorly, you will find that it is present, it is related with the full of the fat. The fat is present into the all around of the your optic nerve. So basically the whole area is filled by the fat. But in this fat you will find that the ciliary nerve. Now see, this is the ciliary nerve which is giving the this is your nasociliary nerve, and this nasociliary nerve is giving the ciliary nerve, short ciliary nerve. So this fat is punctured by the short ciliary nerve and short ciliary vessels. So what are the contents anteriorly? Majorly you will have the fat, and the fat contains the ciliary nerves and vessels. Now what are the lateral relation? Now when you will see the optic nerve, just lateral to the optic nerve, you will find a very important parasympathetic ganglia, and that is the ciliary ganglia. So ciliary ganglia is present. Now in this diagram you can see that this is our lateral rectus and this is our ciliary ganglia. So this ganglia lies between the nerve and lateral rectus, and it is just lateral to the optic nerve. What is inferomedial relation? Answer is your central artery of retina. Now, see, here we have written that the inferomedially it is pierced by the central artery of retina. Now, this word is quite confusing because when you will see this embryology, which I already explained you in the development of retina also, there is a presence of a fissure on the ventral or inferior surface of developing optic nerve, which is known as optic stalk. And in this area, the hyaloid artery invaginate, and later on this groove will close. So when you will see the adult eye, when you are dissecting, we are using the word pierce because when you will have this artery is entering into the nerve. So you can use the word pierce, that the artery is piercing, but actually it is not piercing. Developmentally it is entrap. So we are using the word piercing, but this concept should be clear in your mind that it is not like that there is a first nerve is formed, artery will come and it puncture. It is not like that. Clear? So when you are using this word, you have to very clear in your mind that it is pierced by the central artery on the inferior surface, but embryologically it is actually trapping of the artery. Clear? Now the central artery of retina is a branch of ophthalmic artery, and at what point it enters into the nerve? Answer is 1.25 centimeter behind the eyeball. That means your whole length is around 5 centimeter. That means the artery is not present in the whole 5 centimeter. It is only present into the distal most, or you can say the area which is near to the eyeball, and that is around 1.5 centimeter. Clear? Now we'll move to the next point. Now, what is the relation above? Now, this slide is the most important thing. Now, this question has been asked so many times because when you will see the superior relation of the optic nerve, you have to understand one concept. What is the concept? Now, if you will see this diagram, now in this diagram, what we are able to understand that this yellow color is your optic nerve, and below that you can see this red structure is your artery. Now, which artery is this? This is the internal carotid artery, which will give the anteriorly ophthalmic artery. Now, this ophthalmic artery, when it enters, it is initially inferior to the nerve. What does it mean? That this is your nerve and this is your artery. Now, but obviously, artery remain inferiorly. Why? Because if you will assume the base of skull, you will have the internal carotid going from below, and it is passing into the internal carotid, into the carotid groove, then it enters into the skull, and then it is making a loop. When you will see the nerve is superiorly, it is entering into the middle cranial fossa through the optic canal. Now, you have to keep this thing in mind that the nerve is above, artery is below. Now, this artery is arising from the internal carotid. So, but obviously, the relation is the nerve is superior, artery is inferior. It cannot like that. From the point of origin, if you will see, the point of origin is artery is inferior, nerve is superior. Clear? Why? Because artery is entering from below into the skull, so it will remain below. Clear? Now, what will happen? This artery is having two options, that it will remain below and enter into the optic foramen and into the orbit. Second thing is, what it will do is that this artery is below, but it crosses the nerve. Now, this is the crossing. So, what is the crossing? Crossing will go from lateral to medial side. Clear? So, this is important, that it is crossed from lateral to medial side by ophthalmic artery. Now, I hope it should be very clear in your mind, which is visible in this diagram also, that this is your lateral side because this is oblique, this is straight side, so this is medial. Now, when you will see the artery, where is the main artery? This is not the main artery, this is actually the branch, lacrimal branch. Where is the main artery? If you will see the main artery in this diagram, this is your main artery. Now, the artery is going like this. This is the main artery. Clear? Now, when you will see this loop, now what this loop is suggesting, that it is going from lateral to medial. But it is not superior. If you will see this part, you will realize that it is dotted, the shadow is only visible because the artery is below the nerve, and then gradually it will come and it crosses like this. So this is the important thing. Now in the same way, when you will see the nerve, nasociliary nerve, in this diagram, what you are able to understand, this is the your fissure. Now this is your superior orbital fissure. This is your optic canal. Now in this, again, if you will see, what you are able to understand here, that this is the ring. In the ring you will have this canal. Now in the canal, this is your artery. Which artery? Ophthalmic artery. This is your optic nerve. Now here, where is the nasociliary nerve? This is the nasociliary nerve. Now see, which is the lateral part of this? Now once you will have the orientation, you will realize that this is the lateral wall, this is the medial wall. Clear? Because this is the fissure, the direction of fissure will say this is the lateral side of the orbit, this is the medial side. That means this is my left orbit. Clear? If I will say this is my left orbit, so this is lateral side, and here you can see the nasociliary nerve is also lateral, and this nasociliary nerve is also lateral. Gradually it will go and it will cross like this. So here also you can see this nasociliary nerve, once it will enter, it will cross like this from lateral to medial. Clear? So this is the important thing to understand, that the superior part of the optic nerve, here you can see there are three words. Superior part of the optic nerve crossed from lateral to medial side. Now these two things are important. What are these? Nasociliary nerve and ophthalmic artery. So ophthalmic artery is below, then gradually it shifts on the lateral side, gradually it shifts on the superior side, and gradually it comes on the medial side. So it will go from lateral to medial with a spiral course. In the same way, nasociliary nerve will go from lateral to medial, and ophthalmic vein comes from medial to lateral, and it will enter into the your cavernous sinus. So these are the three important things which has to be there in your mind whenever you are reading the optic nerve. Name the structure on the superior surface. So one nerve, one artery, and one vein. I hope it is very clear to in your mind. Now this diagram is, again you can see in this diagram also, that when you will see the this artery, here the artery is on the posterior side, but gradually this artery comes and then it will make a loop and comes on the medial side. So this is the looping of the artery. Now this is the looping which is visible here on the superior surface. So the artery comes from lateral to medial on the optic nerve. Now this is your vein. Now if you will see the vein, this is the medial side. From the medial side, the vein is coming on the lateral side, and later on it will enter into the cavernous sinus. Now what is present below? Now below the optic nerve in orbit, you will find one branch of the inferior division of oculomotor that is going to the medial rectus. So dear students, when you are reading the orbit, what is the most important relation? On the superior part of the orbit. Now we'll see the relation in the canal. Now when the artery and there are two structures are present into the optic canal. One is the optic nerve itself and another is the ophthalmic artery. So ophthalmic artery is present on the inferior side and lateral side, because I just explained you the relation and the reason why it is inferior. Clear? Because the internal carotid going from below, so it is inferior. Clear? Now what will present on the medial side? Now this is the question of your exam, because when you will see the medial relation, now here in this image you can see that this medial wall, as I already told you, this is straight and lateral wall is oblique. Now in this medial wall, here you will have the ethmoid bone in the midline, and posteriorly ethmoid is going to articulate with the sphenoid. Now here you will have the, what is that? These are the sinuses. These are air sinuses. So posterior ethmoidal sinus now comes here in relation with the canal, and there is a sphenoidal air sinus also come in relation with the canal. So this canalicular part related with the posterior ethmoidal air sinus and sphenoidal air sinus, and they are separated by a very thin layer of the bone. So sometimes there is a sinusitis in these areas may causes retrobulbar neuritis, that means irritation of this canalicular part of optic nerve. So it may be asked as a MCQ sometimes. Now, what is the relation in the cranial part? That means once the the optic nerve enters into the middle cranial fossa, you will realize that as soon as the nerve enters into the middle cranial fossa, this is the nerve which is entering into the middle cranial fossa. It lies below this area. Now, what is this? This is the frontal lobe. This is the frontal lobe. So, where you will find the optic nerves in the middle cranial fossa? Just below the frontal lobe. So, above what you will find? Frontal lobe. Now, which part of the frontal lobe? You will have gyrus rectus. Gyrus rectus is the gyrus of the frontal lobe present on the inferior surface along the medial margin. And along with that, there is a presence of posterior most part of the olfactory tract, and it is also related with anterior cerebral artery. Now, what is the lateral relation? Now, if you will see the optic nerve, laterally you will have this internal carotid artery which is going to terminate into the two branches, anterior and middle cerebral. So, when you are seeing the middle cranial fossa, as soon as you will do the dissection and remove the brain, you will find that once you will remove the brain, you are able to see this structure. Why? Because this structure lies deep to the frontal lobe and it is related with the gyrus rectus of the frontal lobe. Now we will talk about the blood supply. The optic nerve is basically supplied by the two sources. One source is the pile sheath plexus. Now, what is pile sheath plexus? I just told you that pyometer is highly vascular layer. So there is a plexus is present in the pyometer which is contributed by the three main arteries: ophthalmic, posterior ciliary and superior hypophyseal arteries. Now the plexus of these three arteries are supplying it from outer side. Apart from that, the central artery of retina itself gives the branches which are supplying blood to the optic nerve. So optic nerve is having the pile sheath as well as intraneural branches of central artery of retina. Now, what is the venous drainage? Central vein of retina is the venous drainage. Now, what are the central connection? That means optic nerve taking the sensation from retina to which part? So, it is taking the sensation to the midbrain. It is taking sensation to the thalamus. Which part of thalamus? Lateral geniculate body. From thalamus, it is also having cortical connection to the occipital lobe in the primary visual cortex. So these are actually the part of your visual pathway. But apart from that, there is one important connection, and that is with the hypothalamus. Now there is a suprachiasmatic nucleus present just above the optic nerve chiasma. So some fibers will enter in the superior hypothalamus. The hypothalamus is superiorly related with the chiasma. So some fibers will go into this suprachiasmatic nucleus, and which is the central clock, and it is responsible for helping and maintain the biological circadian rhythm with the help, and it is helpful to regulate with the light. Clear? So this is the central connection of your optic nerve. It is connected with the midbrain, thalamus, cortex, and also with the hypothalamus. Now we'll talk about some important applied anatomy. The first question is that if there is a complete lesion of one optic nerve, then what are the manifestations? That means you will have, this is one eye, this is another eye, this is one optic nerve, this is another optic nerve. Now, if the question is saying that if there is a injury, if we will cut one optic nerve completely, what are the effects? But obviously, this eye person is not able to see. So there is a total blindness into the affected eye. Now, what is the another effect? Now, if you are putting the light here, if I am putting the light here, what will happen? This light will not go because you have already cut the optic nerve completely. So there is no sensory input. So no sensory input means there is no light reflex directly here and no consensual light reflex on the opposite eye. Why? Because this sensory transmission is not there. So loss of direct reflex as well as there is a loss of consensual reflex. Now what is the third effect? But there is a retention of consensual light reflex. That means this eye is normal. So if you are putting the light here, this will definitely affect here. Why? Because the efferents are normal. We have cut only the optic now. We have not cut the efferents. And that's why the consensual reflex will show if we see the light on the normal eye. So this is clear. Now the accommodation reflex. Now what will happen about the accommodation reflex on blind eye? Is it there or not? So the dear students, this is the important thing to understand, that if you cut the optic nerve and if you will see the accommodation reflex on a blind eye, it is present. It is not absent. Why it is present? Because again, the efferent comes from the oculomotor nerve, not by the optic nerve. Optic nerve is the afferent. But why it is present? So let's see this here. Now here you have to understand some important concept. The question is, why accommodation preserved when one eye is blind? So in blind eye, why accommodation reflex is present? So there are three important things which you have to write down in exam. First is the accommodation reflex uses the normal eye, because there are two nerves, right and left. Suppose right optic nerve is cut, but still the sensory input are going by the left eye. So the normal eye is using for the accommodation reflex, and visual impulses are still traveling through the normal optic nerve. Clear? So the blind eye is not used. This should be very clear. Second thing is the cortical processing is intact. That means there is no injury into the brain. There is an injury only into the optic nerve. So the input is already been entered with the normal eye, and the processing occurs at the cortical level. Why? Because we already discussed this, that accommodation reflex is a cortical reflex. It never depends on the optic nerve of the blind eye. We are not dependent upon the optic nerve of blind eye, because inputs are all still going with the normal eye. So the processing will there. These impulses which are entering from the normal eye is now going to enter into the visual cortex, to the frontal eye field, and from there to the third cranial nerve. The third reason is the common efferent pathway for both eyes. That means there is a bilateral connection between the oculomotor nerve nuclei. And because of this reason, the common efferent pathway is there for, and it is there is a connection between the nuclei of both the oculomotor nerve. Clear? So this is the important thing, that blind eye still show the pupillary constriction, lens thickening, and convergence, since the oculomotor nerve of blind eye is normal. We are talking only about the injury of optic nerve, not the oculomotor nerve. So this question has been asked in exam, that if person is having a one blind eye, still the accommodation reflex is present. Why? Because opposite eye is normal for the input, and both the oculomotor nerves are normal for the efferents. Clear? Now, this is the chart. If you want to see the comparison, that if there is a blind eye, one normal eye, what will be the effect? So vision, but obviously blind eye absent, light reflex is absent directly, consensual is present, and accommodation reflex is present. So this table is important to understand this concept. Now we'll move to the next slide. Now there is one more important thing, is known as Foster-Kennedy syndrome. Now this syndrome occurs when there is a tumor in the lower part of frontal lobe. Now this lower part of frontal lobe tumor compresses the optic nerve of one side. So there is an optic atrophy occurs on the same side, but the same way, because the intracranial tension is become high, the contralateral papilloedema is there. So papilloedema in the contralateral eye is seen, and same side optic nerve atrophy is seen. Now we move to the last slide of this class. What is the optic neuritis? Itis means inflammation. So inflammation of the optic nerve, which maybe occurs because of the any cause. For example, I told you, if there is an infection or inflammation in the ethmoidal sinus, it can spread to the orbit, clear, by the medial wall, and we have seen that this medial wall is in direct relation with the canalicular part. Second thing is, it can give rise to the inflammation around the optic nerve. Now, whenever the person is having optic neuritis, he presents with the painful eye movement and visual impairment. Clear? So, dear students, by the end of this session, you are able to understand that whenever you are reading the optic nerve, it starts from optic head, ends at the optic chiasma, divided into the four part. Now the important thing is that it is surrounded by the dural sheath, pia mater, arachnoid mater. It is not a true peripheral nerve. It is known as the extension of white matter, and its myelination done after it comes out from eyeball by the oligodendrocyte. There is a lack of neurolemma, that's why it will not regenerate if it get damaged. And the important thing is that when you will read the optic nerve, you will realize that this nerve is compressed into the raised ICT because the subarachnoid space is present. And the most important relation is that superiorly the nerve is crossed by three structures from lateral to medial. What these are? Nasociliary nerve, ophthalmic artery, and superior ophthalmic vein. So this is all for the session. Thank you and bye-bye.